Welcome to This Explainer. If you're tuning in right now, odds are you've just welcomed a beautiful baby boy into the world. Congratulations. But you might also be feeling, well, a little overwhelmed by a new medical term your pediatrician just dropped on you. Listen, I totally get it. Hearing that your newborn might need surgery, that's incredibly daunting. But let's just take a deep breath together. You are in exactly the right place. Today, we're going to walk step by step through the clinical facts and the practical advice around hypospadias. We want you feeling informed, prepared, and above all, reassured.
You know, it's completely natural to feel anxious when you're told your baby's anatomy developed a little differently in the womb. You're probably wondering, did I do something wrong? Or what does this mean for his future? Please, hear me on this. You did absolutely nothing wrong. This is actually a very common congenital condition. And the best part, it's highly treatable. By the end of this explainer, you'll see just how routine the path forward really is.
Okay, let's look at our roadmap. First up, we'll cover what hypospadias actually is. Then, we'll look at the different types, the goals of the surgery, how doctors manage anesthesia and pain, and finally, wrap up with some crucial post-op care tips for you, the parents.
All right, Section 1. What is hypospadias? Let's define the condition.
So, in plain English, hypospadias is a condition that happens during fetal development where the urethra, the tube that carries urine and eventually semen, well, it simply didn't finish extending all the way to the very tip of the penis. Instead, the opening, which doctors call the meatus, forms somewhere on the underside. That's really all it is. It's basically just an anatomical detour that stopped a bit short of its final destination.
Now, you might also hear your doctor toss around another term, chordee. This one often goes hand in hand with hypospadias. Chordee is simply a mild downward curvature of the penis. It's just caused by the way the tissue developed on that underside. I know, it sounds super intimidating, but honestly, it's just a slight bend, and the pediatric urologist will gently straighten it right out during the exact same repair procedure.
Now here is a really crucial point. If your pediatrician even suspects hypospadias, you absolutely must pause any plans for a routine newborn circumcision. I really can't stress this enough. The surgeon is very likely going to need that extra foreskin tissue to expertly reconstruct the urethra. Think of it like, well, specialized surgical material that nature conveniently left right where it's needed.
Moving right along to Section 2, the different types, distal versus proximal.
Medical terminology can definitely be a mouthful, but it's actually pretty simple when we break it down. Doctors classify hypospadias based on exactly where that opening ended up. So, distal or anterior hypospadias means the opening is very close to the tip, usually just underneath the head of the penis. On the flip side, proximal or posterior hypospadias means the opening is further down the shaft or sometimes even closer to the scrotum. Basically, distal is a milder variation, while proximal just requires a slightly more complex reconstruction.
70%, yep, 70% of all hypospadias cases are that milder distal form. So, for the overwhelming majority of boys diagnosed with this condition, they have diversion that is the most straightforward to repair, with excellent, highly predictable outcomes. Huge sigh of relief, right?
Okay, Section 3, goals of surgery, correcting hypospadias.
The standard clinical recommendation for doing this surgery is between 6 and 18 months of age, with 12 months often being the sweet spot. Now, why that specific window? Well, it perfectly balances safety with your child's development. At 6 months and beyond, babies actually handle anesthesia incredibly well. And by getting the surgery done before 18 months, your child is essentially unaware of the whole thing. They won't remember a thing, which is exactly what we want to support healthy psychological and emotional development as they grow up.
So, what actually happens in the operating room? Your pediatric urologist has a very structured, routine checklist. First up, they straighten the penis, correcting that chordee we talked about earlier. Second, they reconstruct the urethra so the tube reaches all the way to the tip. And third, they reconstruct the surrounding skin. This step often includes doing a circumcision at the same time to make sure everything looks totally natural. It's a very refined, very practiced sequence.
Next is Section 4, anesthesia and pain, keeping baby comfortable.
Look, it is terrifying to think of your baby being in pain. I know, but modern pediatric pain management is honestly extraordinary. Doctors use a highly effective dual approach. Your baby will be under general anesthesia, meaning they are completely asleep and totally unaware. But at the same exact time, the anesthesiologist will administer a regional block, like a caudal or penile block, that completely numbs the area locally. What this means is that when your baby wakes up, they aren't waking up in severe pain. Plus, it's exactly what allows you to take your little guy home that very same day. And to give you even more peace of mind here, pediatric anesthesiologists don't just guess. They follow incredibly strict, heavily researched protocols from organizations like the Society for Pediatric Anesthesia. These guidelines are designed specifically for infants undergoing this exact procedure. They make absolutely sure that the medication dosages are perfectly tailored for maximum safety and, of course, maximum comfort.
All right, bringing us to Section 5, Post-Op Care, Recovery at Home.
Here is your first golden rule for home recovery. Keep it dry. Your child will likely have a small temporary catheter in place for the first week or two, just to help the new urethra heal. During this time, tub baths are strictly off-limits. You are basically going to become a master of the sponge bath. Keeping the surgical site clean and dry is absolutely essential to preventing infection and ensuring that delicate tissue heals perfectly.
Next rule, you've got to modify clay time. For about 2 to 3 weeks, you must avoid putting any pressure on the groin area. That means absolutely no straddle toys. So no rocking horses, no seesaws, no bouncy jumpers, and actually scratch that. Even carrying your baby on your hip in a way that straddles their legs is a no-go for now. Keeping pressure off that healing tissue prevents complications and really protects the surgeon's hard work.
Now, I really want to prepare you for this next part because it catches a lot of parents off guard. Please don't panic over appearances. In the days following the surgery, the site is going to look swollen, bruised, and discolored. Frankly, it might look a little scary, but that is completely 100% normal. It's literally just the body's natural healing response to surgery. All that swelling and bruising, it's going to gradually fade away over the next 1 to 2 months. While recovery is usually super smooth, you do need to know your red flags. You should contact your doctor or head to the ER right away if your baby develops a fever of 102 degrees Fahrenheit or higher, if they suddenly can't pee at all, if they have severe discomfort that just isn't touched by their pain meds, or if you see active, excessive bleeding from the surgical site. Knowing these triggers keeps you empowered and in control. I want to leave you with a really powerful reminder from the medical experts at the Cleveland Clinic. They note that hypospadias repair has a very high success rate. The long-term outlook for your son is fantastic. The ultimate goal is to create a penis that looks completely normal and functions completely normally for urination and, much later in life, sexual function. You're basically just taking care of a minor developmental hiccup right now, so he never has to worry about it later. Well, we've covered a lot of ground today, transitioning you from a worried parent to an informed advocate. You now understand the condition itself, the procedure, the safety protocols, and the recovery steps. So, armed with all this knowledge, what are the most important questions you're going to bring to your child's pediatric urologist at your next consultation? Write them down, take a deep breath, and know that you and your baby are going to get through this just fine. Thank you so much for joining me for this explainer, and I'll catch you in the next one.